Okay, let's talk a little bit about imaging trauma. This is chapter 12 in our textbook. We're going to look at a number of different types of trauma and use some terminology, carefully define some terms that are found in our textbook as well. I like this textbook again because the stuff that's found in blue are the key terms. And a lot of what we're going to be doing is defining different types of fractures, but we'll also be talking about things like concussions, contusions, subluxation, stuff like that. So here's the learning objectives. We're going to talk about how traumatic death works. We'll talk about signs and symptoms for diagnosis and treatment of trauma. And we'll kind of break it up by different sections of the body. A lot of this is going to focus on the head, the vertebral column, and skeleton, because that's where most of our focus is as x-ray techs. Like I mentioned, the abdominal stuff or the chest stuff, a lot of times is being referred to CT. And then we'll talk a little bit about our techniques to be used for this. So trauma, like I've mentioned earlier, is the most common cause of death for individuals from about age 1 to 40 years of age. We talk about having a trimodal distribution. And so we'll look at how that works, but that's basically saying that in reference to when the injury occurs, we've got periods of hours where we expect death. So the first amount of time is really just within minutes of the accident. Let me see where this is at. This is on page 368. So there's this first critical period within seconds or a minute of the injury, and oftentimes what we're talking about is brain or spinal cord or heart or greater vessel injury. The second critical period is about 4 hours after the injury, with deaths generally resulting from intracranial hemorrhage, lacerations to the liver or spleen like what we just looked at, or blood loss from multiple injuries. And the third critical period is days to weeks after the injury, and a lot of times it's things like sepsis or infection. So one of the things that, like, for example, Regional 1 boasts about is how well they're able to stabilize people within 24 hours of an incident because of these. That covers those two modes, those first two modes of death. That first 24 hours covers that time. Oftentimes we're going to be working with emergency medical personnel and some kind of trauma center designation. So a level 1 trauma center, like Regional 1, has some kind of key element. It's going to have 24-hour in-house coverage. There needs to be prompt response from specialists like orthopedists, neuro, and then generally they have to have some kind of specialized critical care unit. Like for Regional 1, it's a burn unit. But you'll see other types of critical care units available on site. Some places it's neurosurgery. So each one of them kind of has their specialty. The level 2 and level 3 trauma centers, so level 2 is most common. So most of the facilities you're probably working at are level 2. This is going to, so they have the 24-hour coverage. A lot of times the thing that distinguishes them is they may not have the in-house specialist, like the burn unit, and they also may not be held to quite the same response with things like stroke protocols and stuff like that. Oftentimes they're still trying to make sure that they are compliant with all the protocols for level 1. And then level 3, these are more like rural hospitals, and their main task is stabilization, assessment, and then getting them on a life flight helicopter or an ambulance to a larger facility if they need anything more than just orthopedic surgery. So here's an example of these distributions for different times of death, and we see the majority of them occur immediately. We see another bump around hour 2, and we call these early deaths, and then finally late deaths are like within that range of like 2 to 3 weeks out. Those are the ones associated with infection. CT really has become critical to our assessment of trauma, but the appropriateness of CT examination is continuing to be evaluated. So oftentimes people are relying on certain types of assessment on the front end and then referring them to CT. So he talks about that here on page 370, that looking at these ACR rules, they'll look at things like a Glasgow coma scale and other things like evidence of a fracture or headache, and then they refer them to CT. But oftentimes, if there's obvious, external injury, they go ahead and just take them on over to CT. One thing that's significant, and I know sometimes we don't really quantify why there was this big shift. For example, when I first started out in X-ray, we did a lot of 7-view spine X-rays, like cervical spine X-ray. We did them all day long, and it took a long time, even as a good tech. Like, it would take you like 45 minutes to do this exam, right? That was like the facility's protocol for any kind of clearance of the C-spine collar. And then within a year or so, I saw this shift over to CT. And the reason for it is CT has a 98% specificity for pathology, compared with the conventional radiography, it's 52%. So that's just kind of a lawsuit waiting to happen when you see that range in specificity, and CT kind of, there are things that it still, X-ray still shows better. X-ray is going to have a lot more spatial resolution. So if there's a very fine fracture, sometimes it's more detectable on X-ray. And then X-ray has the advantage of, as we're looking at these images, we don't have to do any kind of reconstruction or to see a true sagittal. With CT, sometimes the sagittals, a fracture can get lost in those sagittal cuts. So there still is definitely a place for things like a cross-table lateral C-spine in trauma protocols. So it's very important anytime if you're responding, if you're a person who sees a motor vehicle accident and you're trying to help them in preparation for the ambulance's arrival, it is really, really important, especially if the individual's in shock, to communicate to them that they need to hold still. That's probably the single most important thing that someone can do prior to the arrival of an ambulance. And so that coaching to hold still, to keep their head still, to not move around, to not try to stand up, anything like that. Again, if the individual is in shock, they can become combative on that one point, right? So you really need to hold still. It's important for you to hold still until we get the ambulance here, et cetera, et cetera. The same is true as we're working with the patient. They're going to ask us, will you please take off the collar? This thing's choking me, all of those types of things. Please make sure that it's important that they understand that they need to hold still. It is never, ever, ever at your discretion that you can remove a C-spine collar, right? Even if the person has like a locket or something that's obscuring your images, it is better just to leave it in place, do the imaging that you can, do not remove the collar. That would be an awful way to injure someone and to lose your job. So mechanisms of injury to the vertebral column can include things like direct trauma as well as whiplash. So whiplash are these hyperflexion extension injuries where you have fracture caused not from direct impact, from the kind of flopping around of the spine during the deceleration or something like that. We can have compression fractures from falls or from other types of deceleration. It is important to evaluate neurological function. That's including things like the ability to feel the bottom of the feet, which is part of how they assess neurological injury. And then there are stable and unstable injuries. So a person may be just fine, right? And we've all heard these horror stories about the person appeared just fine. We didn't really see anything on the X-ray. We removed the C-spine collar. The patient went to go to the bathroom. On their way out the door, and they fell down and died in the bathroom because they had a undetected like C2 fracture or something like that. And these are just examples of compression fractures here. This is page 373 in our textbook. So having a good idea of the vertebral anatomy of the spine will help you a lot in looking at these images and making sure that you've got what you needed on the picture. So what's the size, the shape, alignment of vertebral bodies, how the spinous processes are situated, what the shape of the body should be at different levels, because some levels like C1, C2, again, the bodies have strange shapes. Looking at the position of the odontoid process, the facet joints, the relationship of C1 to the occipital bone, is it displaced in any way? Any kind of laminal lines, how they're lined up, and then sometimes swelling, or what we call a fat pad sign. So here's a very clear image of a C2 fracture. Right? I don't think this is in our textbook. Let me see. It is. Page 370. This is a coronal view from CT imaging. Right? Here's a very subtle thing. This is a lateral cervical spine that has a Hangman's fracture on it. So this fracture gets its name from injury, like from a rope or something like that, to the top part of the spine. And it's important to look at this laminar line in relationship to the posterior process of C2. So we can see it's tilted in a funny way. X-ray can be used to evaluate injuries to the skull and the brain. And oftentimes these things are synonymous. So anytime we're looking at the calvaria, the cerebral cranial fractures, we're talking about linear fractures, similar to that closed fracture that we looked at earlier on CT. Depressed fractures where the skull actually protrudes inward into the brain. And one of the most difficult ones to evaluate is a basilar skull fracture. This is pretty much impossible to make a determination on based on X-ray, but again, CT can demonstrate that. It's important for us, if we're dealing with a patient who's got any kind of injury to the skull or the brain, that we document any changes in patient condition. And those changes can happen pretty quickly. So that would include things like having a seizure, all of a sudden don't remember the day or what's happening to them, things like that. Here's an example of linear skull fracture. And this came from, according to the textbook, came from striking the head in the bathtub. This looks like an old film image. So again, most of these patients are being referred to CT now. It is helpful, though. Here's an example of a depressed skull fracture, probably caused by getting hit in the head with a hammer or something, rock or something like that. So we see that nice, neat line. And if we were to evaluate this on CT, we would see it pressing inward. Trauma to the brain can happen in what we call closed head fashion. So in the textbook on page 377, it has an example of what we're talking about when we talk about closed head injury. So again, anytime we have a whiplash or a sudden deceleration, or maybe a person strikes their head against a wall or hits the floor or something like that, the brain can slosh around and actually be almost damaged by the skull, is the best way to talk about it. So terminology that's going to be helpful for us in understanding stuff like traumatic brain injury and stuff like that is anything the time we've got forces of compression or acceleration that are injuring the brain, we'll call that a traumatic brain injury. So we oftentimes evaluate this based on reporting from the patient, and that would be something related to concussion. So I had a concussion myself when I was young, blacked out, lost memory of things. They took me to the emergency department, and they asked me a series of questions, right, to determine my orientation and things like that. Concussion can include things like personality change, right, depression, stuff like that, even as far as years after the event. I had a friend of mine who had a concussion during a skiing accident. He took his life a year later, right, because of depression from that concussion that happened a year previous. So be aware that just because it seems like you're out of the woods with a concussion or something like that, if you've had a friend who's had a recent concussion or something like that, please touch base with them, ask them how they're doing. And I've shared this with y'all in the past. If you ever wonder about someone, it is much better to ask a question, right? Hey, are you okay? Have you had any thoughts about killing yourself? Just go ahead and put it like that. And let them know that you're not asking them anything that you wouldn't want to be asked yourself. Because I think it's much better to risk offending someone and asking them that question than to have thought, oh, I was wondering, and then not know. We talk about where the lesion or where the damage is in relationship to the impact. So if we call it a coupe lesion if it's the side of impact, a contracoupe if it's opposite the side. Contusion refers to neuron damage, edema, or hemorrhage within the brain. So it is different from concussion, right? And then coma is if any of this traumatic brain injury results in a persistent loss of consciousness. So that sometimes is also referred to as a chronic vegetative state. Brain trauma. So hematomas or collections of blood within the skull are particularly problematic because if you can imagine, I think we've talked about this some in this class, we have a organ that is primarily fat cells or something like fat cells, and it's inside of the skull, and tremendous amounts of pressure can occur and displace things like the brain. So that's why we are concerned with hematomas. We need to understand what their location is in relationship to the layers that encase the brain. So epidural or extradural is going to be out there outside of any of the brain's encasements around the area of the skull. A lot of times it's associated with a skull fracture. So in the case of an epidural hematoma, they can go in surgically and drain the blood and restore a lot of the mental function. The ones that are more difficult to treat are things like the subdural or subarachnoid hematomas. These may be problematic to treat surgically. So here's an example of an epidural hematoma. You can see new blood is that white point there. Old blood a lot of times shows up black on these. And we have that midline shift, the collapse of the lateral ventricle. But as bad as this looks, oftentimes these can be treated surgically and the patient will be fine. I mean, they'll have restored, they'll lose some function, but they'll receive quite a bit of function back. Versus something like this, which appears a little bit more subtle. And so we see that diffuse collection of blood there. It does not have the high pressure that we saw on the other with the epidural hematoma, but it is much larger in extent, and it's pushing over again on the brain, causing midline shift, collapse of the lateral ventricle. These are the ones you don't want to see, right? These are much more difficult to treat. Subarachnoid, pretty rare, but it's beneath that arachnoid matter, so we actually see it going down into the sulci and gyri of the brain, right? And then the rarest is going to be these intercerebral hematomas, and oftentimes these are associated perhaps with trauma, but it could just be a bleed of an artery or something like that. So this may not be traumatic in nature. All right, switching gears just a little bit, we'll talk about fractures of the skeleton. So anytime we have a discontinuity of the bone caused by mechanical force, we'll call this a fracture. if we have delayed union, it means the fracture is not healing. And there's a number of things that can cause that. Everything from the person just being an idiot, not following doctor's orders, to pathological processes, cancer, things like that. That was when I was working as a radiation therapist. That was one of the main fears that a lot of the cancer patients had, was that they would fall and break something, right, because of the difficulties associated with healing while you're under chemo or something like that. Malunion means it's healed, but it's in a bad position. And oftentimes, if the patient's not received any kind of medical attention, you'll see evidence of malunion. Non-union is the fragments aren't joined at all. So these are all, I want to make sure that these I don't think are highlighted in blue in our textbook, but they are helpful terms to know. And some of them are kind of just implied by their name. So looking at this healing process on page 385, it is remarkable. Like I was reading this chapter, I was reminded I broke my clavicle a couple of years back, and within a month or so, I was pretty much able to go back to much of the same stuff that I normally do. So it is remarkable, this process. The way that the healing process works is the break will fill with a clot. Then we start to have osteoblasts that appear around the area, or bone-forming cells they create this provisional callus and calcium deposits. And so we will see different parts of this as we do different radiographic examinations during the course of patient healing. So here is an example of a callus formation with fracture that it looks like it was not treated surgically, right? They did nothing to create appropriate union for the bone, and so we have callus formation with malunion, right? It's not united quite right. Here's another example of malunion seen on MRI. And it looks like it's at the point of the distal radius, that radial head. There's some malunion, and so we see changes in the bony anatomy at that point. Perhaps there's not appropriate blood flow that's been restored to the distal radius. So there are additional complications that can come from malunion. Here's an example of total non-union. So within the distal femur, it is not coming back together, right? MRI is showing that it's not coming back together. There's probably going to be necrosis that will start to result from this. So the fracture classifications that are helpful to know on page 385 is an open fracture is any fracture where the bone breaks the skin. I always think about those martial arts movies where they kick someone and the bone bursts out of the skin. I mean, that's what it looks like, right? Closed fracture, sometimes called a simple fracture. The skin's not penetrated by the bone. And then impact fracture, the bone's jammed into another fragment. So we'll look at some examples of that here in just a minute. So a comminuted fracture is one where there's numerous fracture lines extending from a main fracture line. So this is different from multiple fracture. There's a single fracture line, but it has other things like, almost like window glass splintering off from it. And then complete comminuted, non-comminuted fractures, the bone separates into two fragments. And this can happen in a number of different ways. So we've got examples of this on page 387. There can be spiral, like if it's from a twisting injury, a transverse where it's just cut across, directly across the long axis of the bone, and then pathologic in nature, where due to demineralization or infection or something like that, oftentimes it's almost like the bone's just turned a sponge and it's just kind of eroded. So here's a graphic kind of displaying that with oblique, occult fractures. Occult just means it's not detectable on x-ray. There could still be a fracture there, but we can't see it. Open, again, it's broken the skin. Pathological, there's some kind of process that's going on that's caused corrosion of the bone. Segmented, spiral, which I said may be related to a twisting injury. Transverse, green stick fractures, and then impacted fractures are those where the bone's jammed up into itself. There's an example of an impacted fracture on page 387 that happens pretty commonly at the level of the femoral head. So here's just some further definitions. We call it an avulsion fracture if the bone fragment is pulled away from the shaft. Incomplete fractures are things like green stick fractures. There still is a fracture there, but it doesn't go across the entire bone, so a portion of the bone is still intact. If there's a bulging cortex, we'll call this a buccal fracture, or sometimes a bucket fracture, things like that, just describing its shape. Growth plate fractures, so this has to be a child, but if a portion of the epiphyseal plate is sheared off from the end of the bone, we will call that a growth plate fracture. And there's a special scale used for expressing those. I'm trying to see, do I have an example of that here? I think I have one later on for us. Stress fracture, this is from abnormal degrees of repetitive trauma. So I've been training for the marathon again, or actually the half this year, and very often in the course of training we'll have at least 2 or 3 people who fall off due to stress fractures, like they maybe didn't have appropriate gear, or there's been demineralization of the bones due to age or something like that. They get the stress fracture. It is still a fracture. I had one individual in my Bible study who, she had a boot on, she'd been training for the marathon, and I saw her, she said, I'm thinking about still running. And I said, no, you have a fracture. She's like, well, it's just a stress fracture. I said, it is still a fracture. Just because we put stress in front of it didn't somehow like de-stress it or something. You don't just need to relax and calm down and the fracture goes away. Fatigue fractures, so it can be resulted with unaccustomed activity. And then occult fractures, there's clinical signs but no radiographic evidence. All right, some of these I think some of us have written papers on and things like that, but it is helpful to review these. I have seen registry questions that ask us specifically about each one of these, and part of it is it allows us to think about bony anatomy, mechanisms of injury, and how that would impact the bony anatomy. So we'll be looking at images of these for the activity today as well. So I will be asking you to describe what you're seeing on the images, okay? So let's carefully describe what a Colles fracture is. This is the distal inch of the radius, right? And the fragments are going to be angled back along the shaft. Sometimes we call this a dinner fork deformity, and we can see that dinner fork on the skin. It's a contour on the skin where the fragments of the fracture are poking up into the skin, and it looks like a dinner fork. A Smith fracture is the opposite of a Colles fracture. It's displaced towards the palmar surface, right? So we would not see the dinner fork on the back of the hand. We would see it on the front. There would be something displaced into the front. A boxer fracture is the metacarpal, and we have examples of that. Let me see. I lied. Maybe somewhere in our textbook. A Bennett fracture is fracture and dislocation of the first carpometacarpal joint. So sudden deceleration into the area of the thumb, dislocation, and fracture at the base of the thumb. We'll call it Bennett fracture. Monteggia fracture is the proximal ulnar shaft with anterior dislocation of the radial head. So the ulnar shaft is broken and the radial head has dislocated. And that makes sense. If we broke our arm up here, that it would cause dislocation. A Pott fracture is an ankle fracture. These are really ugly looking. It'll involve both malleoli and joint dislocation. So it looks like your foot has just fallen off the end of your leg is what that looks like at that point. And a Maisonneuve fracture, it will be a severe ankle sprain, right, with a fracture of the proximal fibula. And this is one of the most devious ones out there, right, because the patient may mostly be complaining about pain in their ankle and not talk anything about pain more proximal, right? But a lot of times we'll see a fracture here on the upper part of the fibula, right, associated with that sprain. So here's a Colles fracture.
Is there a Pott's fracture of the foot?
There may be. Like toes?
It's like one of the metatarsus.
I think that's right, yeah. Yeah, I think that is right. So Colles fracture so we have, the Colles fracture is describing specifically what's happened with the radial head, but we also see an associated ulnar fracture. And this comes from a person falling and putting their arm out, sudden impact there. Boxer fracture, this is named this because the person had their fist and they struck something, right? And it breaks that fifth metacarpal bone. Here's one of the ones that's pretty ugly. So proximal ulnar has been fractured and we've dislocated the radius. Here's that Pott fracture that I said was so ugly looking, where we've just stepped off and broken or dislocated both of the Mortise joints. So here's an example of a Maisonneuve fracture where we've got an ankle sprain, but where did the fracture happen? On the proximal portion of the fibula. Sometimes when we're looking at a fracture, so here's an example of an occult fracture. The fracture is not apparent. When we look at the bone, we can't see it. I can't see it in this radiograph. There's clinical signs, but no evidence of fracture on the x-ray. One of the things we can look for, though, is what we call a positive fat pad sign. This is an anterior displacement of a fat pad that's supposed to be situated between the bones, right? I don't know if you can see it on this slide image. It may be apparent if you pull this up on your computer. Sometimes it's called a sail sign. It's a little triangular shaped black piece right there. So that's one of the reasons when we're doing elbow x-rays and stuff like that, we still want to see some soft tissue. We want appropriate penetration of the bone, but we also want to be able to see soft tissue as well. So if there's an occult fracture, we can still evaluate soft tissue signs for that. So we can differentiate between the fractures of the calvaria and what we call visceral cranial fractures like facial bones and things like that. This would be caused by like a direct blow, getting punched in the face or something like that. CT, again, like we've already iterated, would be a modality of choice for this. But stuff like the zygomatic arch, mandibular fracture, and maxilla fracture. And these can get pretty ugly too. So here they've placed a marker so that we can see the area of interest here, depressed fracture of the zygoma. If this goes deep, we can have what we call a tripod fracture of the zygoma. I'm trying to see, does this come from our textbook? Yeah, it's on textbook page 403. And the zygomatic bone is going to be fractured at all three sutures. And a lot of times they'll complain about restricted jaw movement because the coronoid process is trapped by the zygoma. So you can see how the mandible is tucked up under the zygoma here. They can't move their jaw. Example of a mandibular fracture. Looks like it's on the body of the mandible moving towards the ramus. And here's the one that I say can get pretty messy. This is a LeFort fracture. So we've got a fracture of several facial bones in this one. Right maxillary sinus, orbital floor, the lateral walls of both orbits, and portions of the temporal bone. So this is where these 3D reconstructions are helpful, in addition to being able to look at the images axially. If a person's struck directly in the eye, we can have what's called a blowout fracture, where the pressure on the eye is transferred to the orbital walls and floor, and it blows out the bone of the orbital cavity. And then also nasal bone fractures. These are still helpful to get x-ray on. CT can scan over them. We might miss them on an axial view. But a lateral x-ray for nasal bones is very appropriate. Also, along with fracture, we can have trauma that results in dislocation. And another word for that would be luxation. Dislocation is probably the commoner of the two. And this is anytime a bone is out of joint or it's not in contact with its typical articulation. This is on page 405 in the textbook. A subluxation is a partial dislocation, and it often occurs or is associated with a fracture. One of the most common forms of dislocation that we see are shoulder joints, and these are readily demonstrated radiographically. So y'all, the juniors right now are looking at shoulder joints and how best to image them, right? Y'all are probably masters of that by now, right? But those views can be very helpful in making a quick decision. And it is, I don't know, satisfying to be in the room when a patient has their shoulder placed back in socket. You just watch this wave of relief across their face. It's pretty remarkable. But we are helping the physician to make a determination whether it's an anterior or posterior dislocation, because that influences the technique that they'll use for relocation. They have a couple of different twists that they can do. Then hip dislocations, these a lot of times are pathological in nature, or there's other things going on that can result in a hip dislocation. And AC separations are probably the last most common dislocation that we see. I've gotten one. They happen in side impact to the shoulder, and it just tears the ligaments there, and you have now you have the clavicle poking up a little bit over the acromion. All right, dislocations of the hip. So here's one that looks like it's pathological in nature. Well, actually, no, it says it's traumatic according to the textbook. That the patient, 25-year-old man whose right knee struck the dashboard of a motor vehicle crash.
Alabama's quarterback dislocated his posteriorly.
Really? During a game?
Yep.
Good Lord. That stinks. I hate it when they get injured in college. Dislocations of the knee. This one looks like it's associated with knee hardware. Here's an example of subluxation from the textbook, and we said that this is a fracture with a dislocation with an associated fracture. So it looks like the fracture is on the distal portion of the, what is it, proximal phalanx. I really don't know how you wind up with this one. This doesn't look like a good day. Final forms of fracture worth discussing are what we call battered child syndrome, and these are fractures that have specific correlation with abuse, and so it's helpful to carefully document what the history is given for the injury, because part of the name of the game here is associating the given history So the caregiver or the family member's history for what happened and the actual injury. So if they say, oh, they fell down the stairs, right? But what I see are these posterior rib fractures. These are highly suggestive of abuse because what's occurred is the child's been squeezed, right? And it caused fractures along the posterior portion of the ribs, right? You cannot fracture that way from falling down the stairs. So history is significant in helping us understand what really happened. So that's why we need both the family history and physical signs. Sometimes the patients are referred for skeleton surveys. You should be aware that if you're working with a patient who's requested a skeleton survey, the individual who's in the room with you may or may not be the child's parent. They might be a foster parent or something like that who's accompanying the child through the survey. So it can be difficult sometimes to get a good picture of what's occurred and to know to what degree this individual is going to be able to help you and things like that. Anytime we suspect any kind of abuse, there's requirements for reporting. I would say as x-ray techs, the first person you should report a suspected abuse to would be the ordering physician, because oftentimes they're already on top of it. But if it sounds like the ordering physician is somehow complicit in this, or they're not going to report it, and you do genuinely suspect that some kind of abuse is present, then it is actually your obligation to report it. Tennessee law says, I don't know, I haven't looked at Mississippi law or Arkansas law, but I assume that the laws are similar, that it says any individual who has reasons to believe that there is abuse is required to report it. And that's required by law. Other examples, so we've looked at other fracture types, but like an avulsion fracture of a long bone, like the legs or the arm, is suspicious of abuse. Spiral fractures of the leg or the arm, particularly if they say, well, they just fell, right? They just fell. The problem with that is, I had a radiologist explain it to me like this once. He said, if I took a stick and I just broke it like that, it would be apparent that if you looked at the stick later on, you could tell me you took the stick and you broke it like that, right? Versus if I took the stick and I twisted it like this, right, and it broke, the fracture would look different. The break would look different. And so that's what we're talking about with these types of history. If the parent says they broke it like that, but what we're seeing is it broke like this, something's not adding up, right? So that's why we need to make sure that we're reporting history carefully on battered child syndrome or suspected battered child syndrome. Avascular necrosis, this is kind of what we were looking at earlier. If we have non-union or there's not appropriate blood supply due to other pathological conditions, we can start to get necrosis at the area of the fracture. This is the case oftentimes lower extremity as well as the shoulder. It can also happen with the scaphoid bone. So this can be idiopathic, which means it's related to other diseases that the patient has, or it can be post-traumatic, that there was rupture to the blood vessels and it was never really referred again. The non-union case we looked at earlier for the knee, you'll remember, it was an MRI image. And leg calf Perthes disease is just a common form of avascular necrosis that affects the femoral head, sorry. Here's an example of what we're talking about on this. So you can see that erosion of the area of the hip joint. We will call that a leg calf Perthes disease. It's just another fancy name for avascular necrosis. We're going to breeze through trauma of the chest and abdomen, because this stuff is oftentimes, X-ray has its role in this, but much of this will be referred to other modalities. It's about 25%. Let me make sure that is still the case. Yeah, textbook still says 25% of all traumatic deaths occur from chest injuries alone. So this is the case for portable chest X-ray as that front line, as we're stabilizing the patient. We can get in pretty quickly, do that chest x-ray, and move on. One of the things that we're looking for is pneumothorax, which is an air bubble basically where there shouldn't be any air. So if we have a rib fracture or a penetrating wound to the chest, we can get an air bubble between the lung and the chest wall. Atelectasis is incomplete lung expansion. There can be a number of things that cause it, including improper chest tube ET tube placement. So a lot of times they'll do the chest x-ray immediately after tube placement, because then we know two things. We know, is there pneumothorax or some other traumatic injury going on, plus is the ET tube in the right place. And y'all are familiar with that term, ET tube, endotracheal tube. If we suspect atelectasis or incomplete lung expansion, maybe from overextension of the ET tube, we'll see elevation of the hemidiaphragm. So on one side, the diaphragm will be elevated, and there's going to be decreased intercostal space. The ribs will start to compress on themselves. And there's a number of different types of atelectasis. A lot of times the treatments relate to respiratory therapy type stuff. So here's an example of absorption atelectasis. You can see that patient's right hemidiaphragm is elevated, right, above the left hemidiaphragm, and we see that the compression's apparent there in that right upper lobe. You can see it even more clearly on the lateral. You can see the fissure where the compressions occurred. Here's an example of plate atelectasis of the patient's left lung. Right? And that plate is just describing how it appears. So not a lot to say about the chest in terms of x-ray. Pneumothorax, atelectasis are two big ones. For abdominal trauma, there's really very little that we can see on x-ray. The one example might be a pneumoperitoneum. If there's air in the abdomen, we can assess that on x-ray. So this is about 15% of trauma deaths, and most of these are going to occur not immediately, but due to slow bleeding or something like that inside of the abdomen, or sepsis related to infectious processes. So gunshot wounds, stab wounds, blunt trauma, rapid deceleration, like what we look at with the liver laceration. Sometimes this, I don't have an example of it here, I don't think. But, oh, here it is. On page 415, we have what's called a football sign due to pneumoperitoneum. Example of blunt trauma to the abdomen, ruptured spleen. And here's that pneumoperitoneum from the textbook. So this is just helpful in terms of seeing where we fit in all of this. So understanding that in terms of that initial triage, we are often there in the room while they're doing that initial triage, doing a chest x-ray, cross-table lateral C-spine, or maybe an extremity exam like an ankle imaging or something like that. If it's any question of something that's happened to the head or to the spine, we're probably talking about CT or MRI. Probably CT first and maybe MRI if we didn't catch it on the CT. For a lot of the other stuff, though, we are going to be referred to x-ray. So things like appendicular skeleton, battered child syndrome, all the necrosis stuff that we looked at, x-rays can be very helpful. MRI can be helpful with the avascular necrosis as well. And then chest, abdomen, and pelvis, I know it has x-ray on here, but the main thing is going to be CT, and the one exception might be ultrasound. So oftentimes what happens, we do a CT, chest, abdomen, pelvis for trauma. They see something suspicious, like a suspect splenic rupture, refer to ultrasound. So ultrasound is going to be the third line of defense to evaluate physiology there in the abdomen. All right, thank y'all.